in a dual presentation by Ms. Michelle Mitchell. And you've met her before. If you were here last week, we had very good attendance. So many of you will already have heard my introduction of her. If you want to see the prior session, it was recorded and is available on our archives. And so briefly to remind you, Ms. Mitchell is an internationally known patient advocate. She began with a long career on the corporate side of healthcare, and then transitioned to patient advocacy as a result of personal and family experiences with illness, as she described in the recording, which I recommend to you if you haven't seen it. So we now come back again, and Ms. Mitchell very generously has agreed to give us more of her time. A week has elapsed since we last discussed it, and Michelle got a lot of feedback and some interesting questions on a survey that we gave last week, and she will directly address those questions, and they'll be directly addressed by multiple of us at this session. So this week, Michelle is going to focus on more of the nuts and bolts practicalities of the idea of a pathology clinic patient consultations from a patient's perspective and from pathologists and clinicians' perspective. And then we'll have a discussion at the end. And I think there are going to be external participants potentially too that Michelle will tell you about too. So this should be extremely interesting. Thank you all for coming again. I see our chair is also present. So it looks like another well-attended event, and this should be of great interest to everybody. Again, it will be recorded for reviewing later. Michelle, thank you very much. We're honored to have you back, and off you go.
Well, thank you, Anne. Thank you for inviting me today and the warm welcome that I've received on both sessions. I'd also like to acknowledge Dr. Cummings and Dr. Howell for making this possible. And I'm grateful for the opportunity and the platform to share my thoughts with you today. During my previous session, I shared with you how transformative my personal pathology clinic was for me and the impact that it had on my overall health. Today, I plan to elaborate on my perspective as a patient and share my ideas on how pathology clinics can be conducted. I'll also provide updates on the progress of the pathology clinic movement, discuss advantages for clinicians and pathologists, and propose some ideas to encourage more individuals to get involved in this effort. Wrapping up the session, I've asked Dr. Buckley and Dr. Joseph to weigh in on your comments and feedback from session 1. But before I proceed, I want to express my gratitude and admiration for the true pioneers of this movement. These pathologists have taught me a great deal and are already affecting change in the patient pathology clinic movement. Collaborating with these empathetic, caring, and unconventional thinkers is an immense privilege. I'd like to share my ideas on how a pathology clinic could be conducted. What should patients know about pathology? Pathology is a vital component of every diagnosis. Patients should be aware that they have the right to access their pathology report and to communicate with their pathologist. Acquiring knowledge about the test administered and the outcome can instill a sense of empowerment. By gaining knowledge from the lab work, patients can develop confidence in making informed decisions. And pathologists play a crucial role in determining the effectiveness of the treatment plan. Through the lab results, patients can have some control over their disease. How should pathologists respond to patients? Having a script developed beforehand to guide the conversation is helpful. After introducing yourself, you could ask, what is your understanding of pathology? To see if the patient is familiar with your role and pathology in general. Explain your role. If you state your specialty, explain what you do. Try to use simple terms to increase the understanding of pathology. Begin with an open-ended question. For example, what is your understanding of your disease? Asking the patient the first question is a sign of respect. It develops a rapport, and it allows you to learn what they already know so that you can begin in that place. You could respond with, what more would you like to learn regarding your diagnosis? This will also allow you to gauge the emotional landscape. Is the patient frustrated, upset, or angry? It's important to acknowledge the emotion before continuing. I wish statements are useful here. I wish there were more options. Perhaps something like, you seem upset. This must be so scary for you. I can understand how difficult this is for you. Ask for permission to continue. I need your help to understand your goals. Would you like me to share what I know? Sometimes emotional responses are diagnosed as questions. Present information in bite-sized pieces. Try to avoid technical jargon or clarify it if you use it in simple language. Demonstrate empathy, pay attention to nonverbal cues, and realize this is not a linear process. If the patient becomes emotional during the conversation, deal with the emotion first. For example, I'm sure you're upset with that answer. Should we take a moment before we continue? Before you share significant information with the patient, such as you could use language like this. This conversation may be difficult. Are you prepared to continue, or do you need a moment? I recently came across an article outlining a gentler approach to conveying challenging news. This technique involves balancing a message of both hope and worry, which I found to be a straightforward yet powerful concept. One example of how to use this technique is, I had hoped the biopsy showed clear margins, but I worry that the disease may have progressed and we're in a different place now. With no established doctor-patient relationship, the discussion may present some challenges for the pathologist. And in general, healthcare providers may not have specific training in delivering serious news to patients. While it's important to bring closure to the conversation, sometimes ending on a positive note may be difficult. I have a question. How many times have you observed delivering serious news in medical school? Well, just like doctors are not inherently skilled in using a scalpel, the same applies to their ability to communicate effectively with seriously ill patients and their families. Whether you're interacting face-to-face or through virtual means, there are programs which can help you learn to share the news confidently. Vital Talk is a program that teaches practical techniques to delivering serious news. The faculty at the University of Michigan Department of Pathology received training on this method, which included sessions where patient advisors, like myself, were in attendance. The instructors who facilitated these sessions included a critical care doctor, a palliative care physician, and a hospitalist. The pathology department faculty who participated in the sessions acquired expertise in applying effective communication skills, which involved research-based training methods, best practice communication techniques and tools, and specific language and terminology to use to address patients facing serious news. The training sessions incorporated realistic scenarios that were created by the faculty members beforehand, ensuring the role-playing exercises were relevant and based on actual experiences. During these exercises, participants applied specific methods, and the team paused at intervals to discuss any challenges that arose. The actors playing the role remained in character which proved to be highly effective and left a lasting impression. And Vital Talk offers a suite of courses, including a Train the Trainer program. I'd like to share just one example of a technique we learned during that session. The group was introduced to the nurse principle, which aimed to instruct the learners on how to show empathy when the patient had an emotional response to information shared. Name the emotion. For example, stating, "You seem frustrated." Understand the emotion. "I can understand how difficult this is." Show respect. "It's not going to be easy to have this conversation, but I appreciate your willingness to proceed." Using supportive statements like, "I wish things were different," or "I can tell you're a fighter. I wish I had all the answers." We were taught to acknowledge the emotion before moving on. This must be so scary. In a moment of weakness, we were cautioned not to make any promises. And finally, explore. When in doubt, ask, "What has it been like for you? Is this a good time for you, or should we reschedule?" It's essential for every physician to develop these skills. Communication is influenced by various members of the care team and their respective responsibilities. With practice and dedication, skills can be honed and enhanced over time, and every patient encounter offers a chance to gain new insights and refine one's abilities. Patients value not only the information conveyed, but also the empathy and concern demonstrated during the communication. Next, I'd like to outline the pathology consultation process. But this overview was developed with a substantial amount of knowledge that I have gleaned from the pioneers I showed you earlier, who are currently running successful pathology clinics in their practices. Dr. Joseph, a pathologist at Tufts Medical Center, created this flyer for her pathology clinic. It's a concrete one-pager that highlights the crucial components of a pathology clinic and emphasizes the significance of establishing patient expectations. And the flyer can be utilized in multiple ways, such as disseminating it in clinics to introduce the program to patients and referring physicians. It could be included in after-visit summaries to let patients know the services being offered by their medical oncologist, or provided during the e-check-in process. Additionally, the flyer and the list of potential questions to facilitate the discussion could be featured on the Department of Pathology website. Now I'd like to share with you an overview of the pathology clinic process. When a patient wishes to have a face-to-face or telehealth consultation with a pathologist, the provider would place an order or referral to start the appointment scheduling process, also known as an REF 532, ambulatory referral to pathology for review with the patient. Alternatively, the patient could contact the pathology department administrative assistant directly to schedule the appointment. The appointment should be held in a secure and confidential location that is equipped with a microscope or screen to facilitate the display of the patient's pathology report and slides. The patient would then receive instructions on parking and navigating within the hospital to the appointment. It's best if the check-in location is in the same clinic where the patient sees the referring physician, if possible. On the day of the appointment, an applicable copay may be collected. The front desk staff will then contact the pathology administrative staff. And then following an encounter, a note should be sent to the referring physician, and a follow-up survey should be provided to the patient. In most institutions, appointment scheduling, including cancellation and rescheduling, is managed by the administrative staff in the pathology department. But in the future, when the patient's care team is expanded in the portal, they will be able to schedule these visits themselves within Epic and MyChart. The patient will be able to choose the pathologist from the name listed on the pathology report. However, at some institutions today, the ability to schedule the appointment and begin the process of documenting the encounter through Epic is already a reality. Dr. Cummings recently shared with me that he's been working for several months toward automating this process. He said, "I'm currently handling and scheduling a billing logistics for a patient who intends to schedule an appointment in June." A very exciting development. This is a tips and technique document that was created for Tufts Medical Center in collaboration with Epic and MyChart developers. The process has been automated for administrative staff or pathologists to schedule the pathology clinic for the patient, and the process is very streamlined. Click to schedule the appointment, select the patient from the dropdown, pick the appropriate pathologist from the pathology resource list, and then within the software, a sample note is already provided for the pathologist. They open the patient chart, insert the boilerplate or smart note, and then customize the wildcard text as needed. This will create the appropriate pathology consult note required for billing the clinic visit. Once the visit is complete, the pathologist would simply input the appropriate diagnosis, determine the level of service. They can even select the quick button to use the most common procedure code, 99203, and then click to sign the note, and the appropriate documentation to bill the visit is created. Generally, the visit lasts about 30 minutes. The most common CPT codes are for these pathology clinics include 99203. However, if more time is needed in the encounter, other codes could be used. Here's a list of additional codes that may be considered based upon the level of service. It should be noted that these codes are the same for both in-person and virtual consultations. And now I'd like to share what I've learned, the pearls of wisdom from those who are currently doing this work. Preparing the patient setting expectations is important. One valuable piece of advice is to establish patient expectations by informing them that your role is to discuss the nature of the disease, but not to provide treatment options. Dr. Joseph recommends development of a sample script. It's worth mentioning that Dr. Cummings, who oversees Duke's residency program, has found it highly beneficial to involve the residents he is working with in patient encounters. According to him, the residents are generally enthusiastic about the chance to interact with patients. Dr. Joseph shared this thought regarding her experience with clinic encounters. These patients are the ones who search for information about their disease on Google and participate in various forums to discuss it. The majority of them visit us not to find fault or criticize our approach, but to gain a deeper understanding of their condition. She also points out that patients typically want to observe and comprehend the disparity between normal and abnormal tissue, as well as inquire about the colors in the slide. Patients do want to know what the purple and the pink colors represent. She further explains, I attempt to clarify the purple region, that the purple region corresponds to the nucleus, which is the cell's brain, and it directs the cell on what to do. It's crucial to allocate ample time for the patient to ask questions before transitioning from one topic to the other. Responding to their questions in a straightforward manner is advisable, and if an answer is unknown, providing reassurance that you will research the matter and follow up either in person or through a phone call is recommended. Dr. Joseph emphasizes that It's essential to use language that the patient can comprehend. She pointed out this example. Attempting to describe ductal carcinoma in situ as a condition restricted within a tube, how the basement membrane deteriorates, and tumor cells infiltrate nearby tissue, requires using vocabulary that is accessible to them. While not all pathologists may be fond of this approach, Dr. Joseph asserts that using simpler language to communicate with patients is vital to ensure comprehension. And finally, it's crucial to be truthful and exhibit empathy toward the patient. Next, I'd like to discuss what I've learned about the current developments in the pathology clinic movement. Hundreds of articles have been published in peer-reviewed journals over the years. Speeches given at various conferences such as USCAP, CAP, ASCP, and more recently, the World Cancer Leaders Summit, and the 34th European Congress of Pathology Conference in Switzerland. These presentations have spurred great interest in forward-thinking pathologists, which have led to the development of cottage industries in healthcare institutions across the US and internationally. The message of pathology clinics has widely been disseminated across various online platforms, webinars, podcasts, YouTube, and panel discussions. Creation of print and video materials and increased visibility on social media platforms like Twitter, Facebook, and Instagram, and in patient support groups. The future looks bright, and the time is right for this concept to catch on. Next, what's in it for you? The patient, the clinician, the pathologist. Several studies have been conducted to gather the perspectives of key stakeholders in the pathology clinic movement. Dr. Catherine Lapidus, a clinical assistant professor and board-certified anatomical pathologist at the University of Michigan, has conducted extensive research to gather insights from patients, pathologists, and clinicians. This study revealed that a majority of patients expressed a high level of interest in seeing their pathology and understanding their slides. Oops, sorry about that. Here we go. In fact, 85% of respondents indicated they were either definitely interested or interested in meeting with their pathologist to review the slides and discuss diagnosis. The main themes that emerged included an increased comprehension of diagnosis or disease, the chance to demystify the diagnostic process, and the belief that having more information could provide some level of control over their disease. In this next study, clinicians were surveyed to better understand their viewpoint on allowing their patients to meet with a pathologist. It included interviews with physicians from various specialties, ranging from trainees to senior attendings. These specialists included pediatrics, internal medicine, surgical oncology, gastroenterology, dermatology, hematology, oncology, and emergency medicine. 83% of clinicians expressed an interest in having a pathologist meet with patients to discuss their pathology. While recognizing the potential for improved patient understanding and emotional processing, clinicians were also concerned about balancing the patient's information needs with potential cognitive overload and emotional distress. If performed effectively, pathology clinics had the potential to enhance clinician efficiency and improve quality of care, among other notable benefits. Overall, clinicians are interested in the potential for pathology clinics when they fulfill a patient's information needs and are optimally performed. Anecdotal evidence was noted in this article. Please help me see the dragon I'm slaying. Clinicians acknowledged that when pathologists meet with patients, it enhances the patient's experience. Clinicians noted that pathologists are the engine that drives the car, and it's important for patients to encounter the entire care team. I ran across this interesting article. According to this article, clinicians are from Mars and pathologists are from Venus. 30% of the time, surgeons misunderstand pathology reports. It was also noted that these misunderstandings can result in the omission of critical data, miscommunication of diagnosis. Dr. Lapidus investigated pathologists' attitudes towards patient pathology clinics. In this study of approximately 200 pathologists, 86% were either definitely interested or interested in meeting with patients. Those pathologists who found the encounters beneficial indicated it could impact patients through cognitive and emotional pathways, improve quality of care, increase job satisfaction, and that integrating pathologists into the care team could save the clinician time, which would allow them to focus more on prognosis and treatment plans. I thought I would share just a few of the quotes that were in this article I thought were compelling. One of the pathologists said, it would give pathologists a fulfilling reason to get up in the morning and would probably regenerate our motivation for completing the less interactive parts of our work. It could contribute to the visibility in our field. The patients have a right to know who the members of their team are, and having more visibility is adding value to our job. Pathologists are well suited to explain complex pathological diagnosis to patients. It's reasonable to imagine increased pathology face-to-face encounters with patients could similarly increase diagnostic accuracy. This is an area ripe for study. Dr. Buckley noted that patients consider the transformation of a sample into a diagnosis as a mysterious process carried out by a black box, which makes pathologists seem like a source of delay. The pathologist's work often goes unnoticed. As Dr. Buckley pointed out, no one knows you're here on a Sunday, working to make sure the diagnosis is correct. In today's environment, the pathologist sends out the path report and then it's crickets. Dr. Joseph aptly stated, patients can now meet the person responsible for tirelessly searching for the correct diagnosis. And she goes on to say, in the next decade, patient-facing pathology practices will become more prevalent, leading to better patient outcomes. And here's a laudable goal, increasing involvement to combat burnout and increase job satisfaction. Today, pathologies and patients already interact. Meetings are held by forensic pathologists with family members of the deceased to honor their loved ones. And cytopathologists meet with patients when they conduct fine needle biopsies. In my view, encounters should not be limited to a one-time occurrence at diagnosis, but should be incorporated throughout the entire life cycle of a patient's cancer journey. And as pathologists become an integral part of a multidisciplinary care team, patients are likely to seek out institutions that provide the service. But I recognize there are challenges: fierce competition in healthcare, declining reimbursement, and the implementation of productivity measures conspire to keep pathologists focused on the glass. Some are reluctant to support the program and think there's no functional need. There's a legitimate concern that the system could become overburdened with requests. However, this could force health institutions to make opportunities for pathologists who opt in to have recognized clinic days on their calendars, just like any other clinician, redefining the role of a pathologist. Here's an idea. Could AI help? Dr. Buckley expressed her opinion regarding the value of AI. If pathologists adopt AI, as Duke Health has begun to do, it provides patients with reassurance and potentially improved productivity. Dr. Buckley pointed out that humans get tired and AI can offer objectivity. And patients will feel more at ease if they're informed of all the diagnostic methods utilized by their pathologist to accurately diagnose their illness. Could this help save time? On a dime, the country embraced virtual clinic visits during the pandemic. The potential to hold patient pathology consultations virtually may make it easier for pathologists to, quote, fit it into their schedules. And virtual visits offer the following advantages and benefits for patients. Family members, such as significant others and children, can attend. It provides access to patients who live in rural areas far from the medical institution. Patients who are unwell can avoid the need to travel to the facility. And virtual visits can be conducted in the comfort and safety of the patient's own home. Here's a novel idea to address time constraints. In this article, a group of pathologists recognized the importance of offering supportive resources to their patients in a creative way. This innovative approach offers patients a direct line of communication with the pathologist, which may ultimately save time for the entire department. The team of pathologists takes turns answering a variety of questions through a pathology messaging pool, which patients can access via a link on their pathology report and/or send messages to the patient portal. The pool is monitored weekly by a rotating group of 5 pathologists. Being on service is a crucial responsibility for pathologists. Despite this busy workload, though, monitoring the messaging pool has not added any significant burden. The pathologists have been able to provide this additional patient-centered service without compromising their primary responsibility. And patient feedback has been overwhelmingly positive, with many expressing gratitude for the prompt attention and increased transparency in their healthcare journey. Could this work? I read this in a recent article. Pathologist as a navigator? This article examines the possibility of using pathologists as navigators. The recommendation is to create a new position or role within the Department of Pathology. Pathology navigators would assist with the overall coordination of care by the healthcare team and interface with patients, addressing time constraints, and without redefining the traditional role of the pathologist. The primary responsibility for this new role would be to communicate diagnosis and surgical pathology reports to patients. This approach allows interested pathologists to opt in and frees up other department resources. Training would be provided for those pathologists who are interested, including interpersonal communication, cultural sensitivity, standard and advanced therapeutics, and methodologies for assessing patient health literacy. How about this variation on the prior idea? A different strategy discussed in this article to help with overburdened pathology faculty includes designating a resident pathologist or fellow to conduct the initial consultation with the patient. The objective would be to evaluate the patient's interest and current comprehension of their diagnosis initially to determine what the patient would like to understand about their disease. As an initial triage prior to the discussion with a more senior staff member, the resident would use a predetermined script to cover key talking points. Subsequently, an attending staff pathologist would be brought in by the resident to address any additional inquiries. The resident or fellow would then prepare a note in the patient's electronic health record, summarizing the information discussed. One more idea. Could this role be expanded? The University of Michigan Department of Pathology recently created open hospitalist positions. Currently, these roles are specifically designed to center around the frozen section service, as well as collaborating with clinical colleagues from the hospital and ambulatory surgical sites within Michigan medicine. As a new pathology concept, these positions serve as a potential basis for a future subspecialization in the field. Might it be possible to broaden the scope of these positions to include direct interaction with patients? How can you become involved? What are some things you can do to join the movement and make a difference? Write about it, speak at conferences, study it. We need hard data on patient outcomes for sustainability. Collect patient satisfaction surveys and testimonials, and do network with colleagues and share lessons learned, but expect missteps along the way. And if you do offer Pathology Clinic, please do advertise the offerings widely in flyers, business cards, websites, after visit summaries, portal announcements, blogs, create videos, and invite patients to contact you through your pathology report. Is this something you could try? In this article, Dr. Allen, a pathologist in Texas, explores the idea of adding a patient-friendly section to the pathology report. By necessity, he says, pathologists use the best diagnostic terminology in the path report. A lot of doctors speak. The result, language the average non-physician or non-pathologist has a hard time grasping. Research indicates that pathology reports are written using a more complex language than most Americans can understand. One option is to incorporate a brief paragraph written in simple language, providing patients with a basic understanding of the disease process, similar to how a doctor might explain it face-to-face. While it may not provide a comprehensive overview, it can still be useful. Additionally, including the pathologist's contact details would inform the patient that the pathologist is the person accountable for the path report and enable them to request further information if needed. Offering links to reputable sites and patient-friendly pathology dictionaries might be helpful as well. And I got some feedback from session 1 from several pathologists there at Duke. I'm just going to read a few of their recommendations. One person said, "One minor suggestion I have regarding the clinical information field that is an obligatory part of our path report in our system. It often comes populated with ICD-10 diagnosis codes that are misleading. For example, surveillance of lung transplant biopsy often comes with a clinical history of, quote, complication of lung transplant. For a patient who is doing well clinically, I worry that this could cause alarm, and I always edit it to something less ominous. Another pathologist at Duke said, some pathologists copy part of a clinical note into this field, but these are often filled with jargon and abbreviations that would confuse me, let alone a patient reading them. And finally, a rational approach to how to present clinical histories in path reports needs to be examined. One final suggestion, include a link to this site, the My Pathology Report website, in your path reports. The NPR website is an important and timely resource for patients seeking information about their own pathology reports. NPR is freely accessible, multilingual, medical education tool created by pathologists to help patients read and understand their pathology report. The website was developed in collaboration with patients and family members like me, so the language is clear and patient-friendly. The diagnosis library includes articles currently for more than 500 of the most common pathological diagnoses. Each article introduces the condition or disease and then highlights notable features that may be included in a patient's pathology report in patient-friendly terminology. In addition, the tool has a pathology dictionary that supplies plain language definitions for many commonly used medical terms. And there's an option on the site to ask for additional information on the Contact Us tab, where a response by a pathologist is sent within a few days. The reply often has added resources and recommendations for the patient to access. I'm honored to be a part of the 9-member patient advisory team. Dr. Wasserman, founder and editor-in-chief, is always looking for pathologists to collaborate with. I was lucky enough to introduce Dr. Catherine Lapidus to Dr. Wasserman, and she wrote a terrific article on kidney cancer and has become a key contributor of NPR. I would be happy to put you in touch with him if you're interested in being a member of the pathologist content team. I'd like to leave you with a quote from Dr. Myers. Here's what he said. Some in the field of pathology are worried that everything they do will be done by others, whether it's artificial intelligence or digital solutions that can be sent outside of our healthcare institution, or tissue which is fed into other analyzers that can compete with pathologists in terms of diagnostic performance. I think if pathologists figure out other unique ways to add value to care, healthcare will not want to live without us, and it's up to us. Again, I would like to express my gratitude for your time, this platform, and your openness in sharing your ideas and thoughts with me. Your commitment to patient-centered care is commendable and truly inspiring. I would appreciate it if you took a moment to complete the survey that Ebony has shared with you in the chat box. Your feedback's important to me as I'm committed to continuously improving the value of the presentation. And if you'd like a copy of the references to any of the studies that I included in this presentation or the prior, please do leave your contact information in the survey or send me an email and I'd be happy to supply them to you. At this time, I'd like to invite Dr. Buckley and Dr. Joseph to share their insights into some of the comments and concerns that you raised during session 1. I'm going to put the slide up now. And Dr. Buckley, Dr. Joseph, please feel free to weigh in.
That was fantastic, Michelle. Thank you very much. And we now have with us Dr. Lydia Joseph. from Tots, who I regard as the mother of this process from the pathologist perspective. Began it all, and she has a clinic established at Tufts that is very successful, and she will be able to teach us a lot, I think. So thank you so much, Dr. Joseph, for coming along. We have some feedback here. I don't know how you want to do it.
I will just go by the way Michelle has figured that, topic listed. I do want to thank you for allowing me to be here, and I do want to acknowledge that Dr. Jiang introduced me to Rachel few years ago at a CAP meeting, and none of this would have happened if she did not connect us. So I do want to acknowledge Dr. Jiang as well as Dr. Cummings, who picked up the phone during that CAP meeting and said, Lija, I don't care about glory. I don't want to be the senior author on a paper. I just want this to happen. And that's how this journey started. So I do want to acknowledge Duke as the mothership for launching this program. So for the legal issues that I do want to share with you, my interview with our chief medical officer here at Lowell General Hospital, I asked him, when you approved us to launch this program, did you ever worry that the patient would sue us, or some deeper knowledge about their diagnosis would cause doubts in their mind, asking for second opinions? Bottom line, he stated to me that no patient has ever sued. He's on the hospital suing committee. He knows about every suing that happens. And he said no patient has ever sued a hospital, at least in his experience, for being transparent with them and for being honest with them, and by trying to explain what happened. In Massachusetts, we have a law called Disclosure, Apology, and Offer, which is trying to encourage more transparency between the patients and the doctors and other providers as well. So, and in my experience of interacting with over 200 patients here at Lowell General, we've never had a situation where the patient said, somebody harmed me, I'm going to sue you. That's never happened. The second topic about documentation and reimbursement, it literally takes 5 minutes because we have created templates which identify certain key language that needs to go into how we document this encounter. It cannot be an addendum to the pathology report, but it has to be a specific billable encounter that goes into Epic or whatever electronic medical record. And literally, you just have to use the template. So it really does not take much time at all. And the reimbursement has been consistent. Most carriers, both Medicare, Medicaid, as well as commercial carriers, reimburse this CPT code. Question regarding restructuring the department, it has been the other way around here at Lowell General. I was the only pathologist who was doing it when we launched this program, but now every Tuesday afternoon, 1 o'clock to 4 o'clock, the pathology clinic is open, and the pathologists take turns to go up there. If it is, every pathologist is doing it now. So it's actually it is just built into the flow of the department operations. So it really did not impact restructuring the department. And regarding time constraints and burnout, I want to acknowledge that, this is not a Pollyanna-ish world. There are 15% of pathologists based on published data who do not want to meet the patients. And we acknowledge that and appreciate that that is a possibility. Those who want to choose to meet with the patients, me included, it has significantly impacted and helped me allay my burnout. even during the pandemic and in my past 5 years of experience meeting with the patients, every single patient has inspired me. It helps me understand my life as it exists is in a better space than most of what they are going through, the stories that they share, but most importantly, the appreciation that they show me and the understanding that comes with knowledge and the peace that they get because they understand what's going on with their disease process gives them control. And that gives me professional fulfillment. It was almost like a hole in my heart that every single one of them fill. And so for me, it has allayed my burnout, but I do acknowledge that there are some pathologists who would choose not to do this. And that's absolutely fine. And I'll stop there and take questions if you have any.
Thank you very much, Judith. Does anybody have any immediate questions? I don't see anything in the chat. And Michelle, you also mentioned that maybe the former editor of the Pathologist might pop in to talk as well to give his perspective. I don't know whether we can see him. Are you able to see the list of participants from where you are?
I was, and I didn't recognize if he was on.
Okay,
So
so he can jump in if he's here. Let's see. Does that feel free to somebody stick a paw in the air if anybody has a question, and I'll recognize you. I do understand the reaction of I got the sense of a mild panic among some people at the thought that their already overloaded schedule would be added to. And I echo what Lydia said, which is that it actually makes your work more enjoyable. This will not be every single patient wanting to talk to you. It will actually be a self-selected tiny minority of your patients, but they will be the ones who will benefit enormously from talking to you. They will be engaged, they will have educated themselves about their disease, and they will be, in general, the diagnostically complex patients. And so I must say, I get energy from this process. Now, do I have time? No, and it hasn't been recognized. You know, and fit it in. But and that's why it's important to have a structure in place, because as Jeff Meyer said, lots of pathologists, like many of us, if not all of us, already do this on an ad hoc basis. But if it's not recognized or seen as part of your workload, you are just going to end up, you know, staying very late, and it won't be seen by your department. It'll be invisible work, and it does take time because you have to prepare beforehand thoughtfully. And there's more work afterwards thinking about it and so on. And it takes energy because you're engaging in a very, you know, it's a hugely important discussion generally. And often patients have been looking for a diagnosis for years, but it is hugely satisfying. And it's the whole, yes, that was there, because I love pathology, everything about it. The only hesitation I had in becoming a pathologist because I was going to lose patient contact. But the kind of patient contact we're talking about here is really meaningful. It's never like a sort of, you've got 10 minutes with every patient crammed into a clinic, which is actually, unfortunately, what a lot of our other colleagues experience. They don't get to talk meaningfully to their patient. They're meeting them, but they're just saying, any side effects? Okay, great, next. You know, it's just, whereas the interactions that we have are with patients who have sought us out specifically. They're generally complex, engaged, and it's just so it's just a very meaningful, limited number, but very meaningful set of encounters that yes, alleviates burnout. If you feel like you've got this disconnect, and now there are fewer and fewer social opportunities, it just takes you out of your office and brings you back to why you're there. So it's benefited me enormously, even though it has taken more time. And I think that over time, because of the Cures Act, pathology will become more visible and our interaction with patients will become more important. And I think it will move into the mainstream. And I think at Duke, it began to crystallize for all of us who were doing it on an individual level when Jiao Dr. Wong, our chair, arrived, because he is a strong advocate of this. And he supported Tom and myself in working in this. And so I think it's beginning to build here into something that is recognized and has a structure. Dave, you popped up. Are you?
Yeah, once again, Michelle, thank you for a very stimulating and thought-provoking discussion. I have a couple of comments and then a question that's sort of a follow-up of the discussion that we've had in the last minute or two. So first thought is that I think if you write your reports in clear, plain language with the notion that write it so that just about anybody could understand it, that it actually not only helps communicating with patients who might see the report, but also clinicians. And as you pointed out, someone estimated that 30% of surgeons don't understand what's in the report, and they'll understand it better if you write it in a clear, sort of plain spoken way. It's also one of my rules of thumb for giving a talk. Try to make your talk so that anybody in the audience can understand it, as you have done. Second thing is not really particularly related, but I do occasionally talk to patients, not only people whose biopsies I've looked at, but also family members and friends who have medical conditions. And one of the hopeful things that I try to stress is that our therapeutic options for just about everything now are better than they were 10 or 20 or 30 years ago. And this is easy for me to do because I've been practicing medicine for decades. So somebody has myeloma, I say, well, it's not really good to have myeloma, but it's a lot better to have it now than it was to have it 10 or 20 years ago. So that's a hopeful thing that you can put in the toolkit for talking to somebody with a bad problem. The question I have, so we've had sort of two very disparate estimates for the number of patients who might want to be involved in a discussion with a patient. Ann Buckley said, very rare event. But I think, Michelle, you said that there's some polls that suggest that like 85% of patients would like to talk to their pathologist. So
That's right.
The truth is probably somewhere in between.
Mhm.
Has anyone studied, and maybe Dr. Joseph can comment on this, because hers is a program that's pretty well developed now. If this thing gets running smoothly and everybody knows about it, how many patients, what percentage of biopsies would you expect to get a query about?
Honestly, here, based on our patient population, it is 1 or 2 patients a week. That at best. So, it's not going to be overly burdensome. We do have patients now. We do have a statement in our pathology report, like Dr. Cummings has, stating in every single pathology report has a statement saying pathologists and medical doctors who look at your biopsy and make diagnosis. If you want to speak to them, pick up the phone and call this number. And we do get 1 or 2 calls a week. So it's really not burdensome.
Thank you.
Yeah, I think the 85%. Yeah, that's a good point, Dave. I think it's 85% of people would like to have that option if they ever needed it, just in a general sense, I think, to know that they could reach their pathologist if they had something other than, let's say, a colon polyp that was fully explained by the report. I'm assuming. And so I think, yeah, because Lydia has been doing this for so long, and it sounds like so it's 1 or 2 a week for you, Lydia, or just for the entire department?
For the department.
Yeah. So
I have a question, Dr. Joseph. Are you advertising this widely as an option for patients?
No, it is just, word of mouth, and our clinical colleagues are just starting to appreciate the value of it. So our breast cancer program truly embraces it. So a lot of our patients are actually breast cancer patients, but we are, I think, prostate cancer patients too, based on the New England Journal article that came out yesterday about, the comparison of active surveillance, surgery, and
Mhm.
radiation outcomes are the same. So those patients may be in order for their, I personally think prostate and breast cancer patients are probably the first ones to engage with this process. That's been our experience as well.
I asked that question because I really do believe if this service is advertised, you'll have more patients who would like to know more about their disease. I don't think patients know that you are the ones. They think their surgeon is diagnosing it, or their medical oncologist is diagnosing it, and you're the best person to explain it. Also, with all of the, genetic testing being done and, specifically geared precision medicine, who's the best person to describe it but you? And I think if patients knew it was offered, I really, really believe that they would gravitate towards those institutions that are doing this kind of work.
Yeah, I completely agree. Actually, we were thinking about finding a celebrity who can go on TV and talk about it. And soon it will be, viral on Twitter or something. So, yeah.
Yeah.
Perfect.
And I see Dave put in the chat that he has seen this happen in real time for a prostate cancer patient, Dave's brother, and a pathologist, Jiao, our chair, which was immensely reassuring and gratifying. So, yeah, I mean, it can be huge. And I've been told over and over again, you are the first doctor that has sat down, taken the time to explain this to me in detail, because our colleagues don't have time.
No.
And we are not in a structured situation where there's support staff that needs to move people through rooms, it's not a great system for our colleagues. And we're a little freer of that. Will.
I was really encouraged to hear you say that you haven't had any pushback from reimbursement, because I do think reimbursement would be a necessary prerequisite to make this work, because ultimately it is time, and that time has to come from somewhere, even if it's pleasurable time and engaging and reinvigorating. Like, time is time. And
Yes.
Particularly if this grows, I would imagine that would be important. The only thing I just wanted to comment, and this is maybe more of a comment than a question, is, you mentioned that the scale currently for both of you is relatively small. If this were to be advertised and the uptake were to be greater, I think the reimbursement would both become more important, and also we would be more likely to experience pushback on the reimbursement. Insurance may not be seeing this, it may be flying under their radar. But if suddenly large institutions, 7,000 malignant diagnoses at Duke per year are getting a new, consultation report, that starts to rise to the level of the attention of those companies. And now suddenly you're dealing with complexities of billing. There's a lot of additional costs that come with, trying to make sure that something can be billed for, and maybe the advantages go down. So I think, in addition to all the things you mentioned, I really think that demonstrating the impacts of this in a measurable way to justify it, and not just sort of have it be highlighted as an inefficiency, is really critical. Because now this is small, but if it's to become big, it won't survive, I don't think, without those metrics.
Yeah. So we have designed a study that's currently in the planning phases for prostate cancer patients. It's a multi-institutional study that we are strategizing in order to demonstrate just that. So, yeah. Totally.
I'm sorry to interrupt, Doctor. I wanted to mention that this is standard of care actually in Tel Aviv at a hospital there, and they did the largest study of patient outcomes, real outcomes, and it was really eye-opening. I could share the study results with you with regard to patient outcomes. People who were misdiagnosed, people who attended these clinics and were recommended to have different diagnostic testing done, and so on and so forth. It was really interesting, and it's become standard of care there in Israel for patients. So that's the only study I'm aware of where real hard data regarding patient outcomes has been studied and documented. I'll include that in the resource list if you're interested.
Yeah, thank you. Yeah, I mean, that's a good point, Will. We can't be sort of, goofily, optimistic about this. It does have to actually stand up in real life, but I do think it will. And that code is an educational code, right, Lydia? And it's
Yeah.
used by clinicians.
It's CPT 99203. It is in one-on-one interaction with a patient between 30 to 45 minutes. It's a CPT code that our clinical colleagues use all the time. So it's a well-established CPT code. So
yeah, and I've seen it used in notes in the context of no physical exam, nothing like that.
correct,
Simply educating the patient, discussing things with them.
correct.
And we would be doing the same thing.
Mm.
So I think it should still fly. And then if we can, as you indicate, we need to demonstrate with more studies that I think will back up the Tel Aviv study. And what we're trying to do is improve patient care. There's no point in doing this just because it makes us happy. It has to
Well,
be-
that's okay too.
that's a nice, but that's only a perk, right? I mean, because
Yes.
if it's not useful to patients, not really concretely useful, measurably useful to patients, yes, insurance won't continue to cover it. And it's not, it's not worth doing if it doesn't help patients better. And from my personal experience, I think patients do benefit, just peace of mind, knowing they're looked after. I've assisted patients to diagnoses that have taken years to arrive at, and so on and so forth. And so it's going to be an increasing number. I think you're right, Michelle, when it's advertised and becomes known. And things will have to change so we can fit it in. I do love the idea, I hadn't heard of that, of the pathology callback pool that could be covered by residents and fellows and backed up by attendings. And that could be huge. Yeah, I like that idea. Do you guys have that, Lydia, at your place?
No, we don't. I just want to acknowledge Ebony. I did not have the link for this meeting, so I was panicking. And I finally just called Ebony and said, I have to be there. Please send me the link. So if there was some statements made before 12:42, I did not hear it, but I will watch the recording. But thank you, Ebony.
No problem. It's now 10 minutes after the hour. Are there any more questions? I don't see any questions in the chat box. And I wanted to thank Ms. Mitchell for joining us and offering a wonderful talk. And thank everyone for attending. And we'll see you all next week for another grand rounds. Thank you for joining us today. Have a great weekend.
Thank you for the opportunity. Thank you all.
Fill out the
Bye.
survey, guys.
Yes, please fill out the survey. Thank you.
Thank you, Michelle. Thank you.
Thank you so much.
All right.